Thank you, Mona, and thank you, Dr. Mohammed Tala. At the outset, I should thank Dr. Gujal and start sharing my screen. So there were 4 cases which we have given. I hope my screen is visible, Mona.
Yes, sir.
Yeah. So there are 6 PG residents, and they are going to take this slide seminar forward. But before we discuss the cases, there are certain basic things which we need to know about how to approach a slide. And I also asked Dr. Verma to intervene anytime in this. So what is the general approach to any case? What is the general? Well, you have to know when you are approaching. So taking a lecture and discussing a topic and discussing a lecture is a simple thing. But when it comes to a day-to-day practice of slide, there are several things in mind. The first thing I want you to remember that you are a clinician. You are post MBBS. You have seen and gone through the wards. You have seen patients. You have seen their X-rays. You have seen the tumor markers, and you have to use your basic MBBS knowledge in your day-to-day practice. Even as a pathologist, even as a surgeon, even as a medical oncologist, everybody falls back on to certain things which go back to the time of MBBS. So the age, site, history, investigations. And believe me, as you grow in your stature and in your age, you will realize that age, history, investigations, serum tumor markers, these are the things which are probably more helpful to diagnose any given slide rather than actual histopathology. That's my thinking, my thought process. People may not agree, but I think the age, site, history, investigation, serum tumor markers, radiology, these are the things which make you understand and approach to the diagnosis in a slide. So when you come to the slide, uh, per se, you have to first and foremost, especially in your exam, Parol and Himalayan, you should all know that you have to first look for any normal tissue. That will at least tell you what normal tissue is there in the slide. So is there a salivary tissue? Is there a thymic tissue? And that clinches your pathway to diagnosis first and foremost. So that's the first thing. You train your mind like that. Obviously, if you know the age history, those are things. But when it comes to histopathology, try to look for normal tissue first. Once you look at the normal tissue, then you know what is the abnormal tissue. And you look at the abnormal tissue with the eyes that is it a benign or malignant thing which you are looking at. And you form an impression, okay, this looks malignant, this looks benign. If it is benign, is it a tumor or is it inflammatory? That's how you approach any slide in your mind. And that's how you train your mind slowly. Uh, Sometimes you know where you keep the slide and you understand and you know what it is. If you don't know, this is the approach to a slide, how you go to it. If it is malignant, you always try to think in your mind, what is the broad categorization of the tumor? Is it a carcinoma? Is it a sarcoma, melanoma, lymphoma? These are the broad categories. If not these, then you start thinking, is that a neuroendocrine tumor? So those are the different things. But in general, if it is malignant, you ask these questions you ask. If the morphology is very characteristic, see it's a squamous cell carcinoma, you know it is keratin and squamous, you diagnose. You don't need any ancillary techniques for that. But if it's a bit confusing, you have to use your IHC judiciously. You have to use appropriate panels. And when I mean panels, you have to use a panel of markers to say, so every panel should have sort of positive as well as negative markers, so help you in diagnosis, because that matters. So if you are confused, please use IHC. Don't be shy to use IHC because it matters in the management. There may be certain predictive and prognostic IHC markers, and that's very important. If subtyping is needed, use IHC. You refer the patient for molecular testing and please order, because this is an era where things are going deeper and deeper into the tissues. And for a given patient, it may really matter those molecular stuff and really will matter, especially in targeted therapies. And most important, many of us are shy. Many of us are egoistic sometimes. But if you don't understand something at all, please take an opinion. Somebody else who sees your slide can quickly snap at it and say this looks like this. So please form a team, form a group of people, have a group of friends and colleagues who can help you in, and you can take their opinion. So that's the approach to any slide. With that, I think I can go on to the case one. Case one, this was the history which was given. It's a 55-year-old male. So this was the referral case from outside. We didn't have much details. The only thing which we had in our form was that the patient had burning micturition for 3 months. And he had undergone a cystourethropy for that. So we did not have ultrasound findings. We did not have urine cytology findings. We did not have urine culture sensitive findings. So those things should come to your mind when you're looking at burning micturition. A UTA is the commonest thing which should be coming to your mind. But once they did a cystourethropy, they found a urethral mass and a TUR of the urethral tumor was done. So what is a TUR or a TUR-BT? What do? They put a scope to the urethra. In this case, it's a male patient, so it goes through the penile urethra, and then they, if it's a bladder tumor, they will go into the bladder and see the bladder. So that's the cystoscopy, and they resect the tumor. That's called TUR-BT, transurethral resection bladder tumor. Here it is a urethral growth. So they found a 2 centimeter urethral growth, and that's how they resected out the tumor. And what we had only slides. We didn't have other findings in detail. And if somebody can show what is going on here, maybe Parul can start with this.
Yeah, sure, sir. Sir, in this case, what I have gone through, there is a lining of stratified squamous epithelium.
So let's discuss this slide first. Yeah, first this slide. What do you see in the screen?
So, stratified squamous epithelium, which is showing orderly cell maturation, and beneath this there is a fibrovascular stroma, which is containing capillary-sized blood vessels, which are some of which are irregular in shape also, and occasionally there are glands also, and which are quite regular and normal in architecture, and also we can see in some edematous changes.
Okay. Okay. So maybe Poonam or Himali can say, is the squamous epithelium okay at this point? We have a urethral tumor.
Euro.
Yeah,
So is there something normal here? What is the normal thing here?
So urothelium.
It's a squamous. This is a squamous metaplasia of the urethral lining. Yeah.
Yes, sir.
This is squamous stage in the. So
Yes.
This is definitely squamous. It doesn't look like typical urothelium for that matter. It's got very pink abundant cytoplasm. The nuclei are very, very far away from each other. You can see a basal layer here. I think I'll put out the laser pointer just.
pointer.
Yeah. So this is your squamous epithelium. So urethra can definitely have squamous change. So this is something which is normal. So first thing you confirm is whether the tissue which they have sent and the tissue which you are seeing is in coherence with each other. Sometimes you get a referral case of something. The first thing to confirm is you're not looking at a wrong slide. Okay? So that's how you approach a slide. And mind you, in your whole career, you will find several times that a wrong slide, you are interpreting a wrong slide, and the wrong slide has been referred to you, a wrong block has been referred to you. So that's why you have to always try and look for something which is normal for that. Okay. So it's a urethra, and this very well works with the urethra. Urethra will show some squamous change, can show some squamous change. That's what it is. And anything else, Jesse, you want to say? You agree with what Parul said, that there are capillaries and there is fibrovascular tissue?
Congested capillaries and some edema can be seen, sir.
Okay.
And
you want me to go to the next slide? In squamous epithelium, little hyperplastic looking squamous epithelium.
Is invaginate.
What do you see here, Ruchika?
Sir, here in the subepithelium, we could see some cystically dilated spaces, along with some edematous changes and inflammatory
dilated spaces. So you mean to say this is a space or this is a vessel?
That is looks like a lymphatic, sir, to me.
Lymphatic or a blood vessel. What else? It's a lymphovascular.
Yes.
Yeah, that's fine. And you see something here and you see something here, which you see are dilated spaces, which are lined by.
Some are lined by cuboidal.
Okay.
Yes, sir. Some are lined by flattened.
Fine.
And inflammatory cells also I could see.
Okay. That's fine. Niharika, you want to add something?
So same. The cystic spaces are of irregular shapes and sizes.
Okay.
And they are lined by flattened epithelium.
My screen showing double screen, is it?
Okay, so it's fine.
You're seeing only one screen. I'm seeing two screens actually. That's fine.
It's fine with us, Santosh. You have to maybe.
Okay.
You want to? If it's a problem, you can log out and join again.
I'll just stop and share my screen again. Just a second.
Take your time.
Yeah. No, it will be in a second. Yeah, that's fine.
It's fine here.
I'm again seeing two screens. Now it's fine. Yeah.
Okay.
So yeah. So Niharika, you were saying that there are blood vessels. So you think these are capillary-sized blood vessels? What about these ones? Parul or? Glands or tubules or whatever you might want to call them. Fine. So there is something here in the subepithelium which is there. What about this section? This is
Yes,
another
sir.
field. From.
Yes, sir. I have some questions in this section also, sir.
Yes.
As we were discussing on 26th of this month,
I am
and
asking the questions. You are asking, giving me the answers.
no, no, no. Okay, sorry,
You
sir.
can, no, I'm just joking. I'm just joking here. Let it be
Okay,
very
sir.
informal. Yeah.
Yes, sir.
So, yeah.
On 26th, sir, we were talking about this slide only, and
Mhm.
people were saying, some of the people were saying that these are capillaries.
Mhm.
I agree. Oh, I agree. These are capillaries.
Okay.
But I said on that day that it looks to me like signet ring cell change.
Very good. Very
Yes,
good.
sir.
Very
Because
good. That's
there,
what I wanted you to tell.
yes, sir. Because
So,
if we clearly see these things, there is plenty of mucin inside them.
there is some mucinous kind of material,
Yes.
and the nucleus is pushed to one corner of
One
the
and
of the field.
eccentrically placed nucleus they
Yeah.
have, and obviously we will never see mucin in any of the capillaries.
Very good. Very good. Perfect. Perfect. Yeah. So that's what I. And there are a lot of inflammatory cells. If you agree or not, I don't know whether you
True.
agree. There are
Yes.
some
I
scattering of
agree.
inflammatory
True,
cells.
sir.
So this is a field where you don't see the tubules, you don't see the gland. This is completely looking like varying size capillaries, query signet ring cells with some mucinous material. Again, higher power shows some more areas. So you have some congested vessels. You have these blank looking kind of capillary like areas, and then you have these tubules. Everybody agrees that these are tubules or glands or
Yes,
acini.
yes, sir.
Yes.
Fine.
Yes, sir.
Yeah, fine.
True.
Verma sir, are they on the right track of thought?
Yes, they are. I think
They are.
they're
Yeah.
getting there. Obviously, there are a few
So
more
they have
points which need to come
so
out.
they have found out that they look signet, and they do think that there is some mucinous material. Definitely in this tubule there is some mucinous material. And some of these kind of things are here, which look like capillaries, and then there are very small, probably single looking cells, but then there are definitely these tubules with this myxoid mucinous kind of material. What about this area? You don't see much signet. It is more kind of a
Cystic
a
change.
very cystic kind of a.
Yes, sir.
And where are the nuclei placed?
So hobnailing appearance.
Hobnail.
Very nice. Very good. So I think you have picked out all the findings in the sense you find that there are some capillary sized vessels and vessel which look like vessels. There are tubules. There are these cystically dilated tubules which have got hobnailing cells. There is some myxoid mucinous material. What else do you see in case before you label it benign and malignant? In general, in cancer pathology or in pathology, before you call something and jump and call something malignant,
So
what
we
is
will
that
look
you
for
agree?
any cytological atypia,
Okay, fine, very
mitosis,
good.
necrosis.
Yes. So please don't forget those basic things in anything. In pathology, that mitosis, necrosis, cellular atypia is very important. Cellularity, these are the things which you look for any pathology to label it as malignant. So in general, you think that these are bland looking or these are malignant, benign. So you have seen normal epithelium, normal squamous epithelium. You think it is benign or malignant, you have to give that thought process, very important. Another high power to show you this.
So
So this is
some
almost.
comment section share it is the signet cell appearance.
Yeah, so this
Yes,
is
sir.
very
This is the classic.
signety. Yeah, classic signet with little pushed nuclei, little hyperchromasia, and you see this mucinous.
A person is requesting that field size should be mentioned, that it is a 10x or 40x. Some of the people requested.
So sorry, I have not mentioned that. Yeah, and I really don't remember. These are old cases of mine, so that's fine. Whatever it is, I think signet is always a signet, whether it is 4x or 10x or 20x. A signet remains a signet, as far as the pathology is concerned. So you see there is edema, and then these are completely. But I don't know whether you noted that they have got very thick kind of this hyaline kind of thickening of this.
Walls.
So in general, a signet would not have this thickening of this material. You can see this hyaline material here, and you see that they have got this clustering and a little thickened kind of appearance. So that can occur in endothelium, definitely. Endothelial cells can have this thickened kind of material in their wall, and they can look like this. Again, a higher power to show this hobnailing of these cystically dilated duct-like structure or dilated acini or gland, whatever you want to call them. There is hobnailing, definite hobnailing. And then that's what I say. You see this hyaline material between these. So this is a aggregate of these cells, which has got a little signety appearance. There are tubules very close by here. Some mucinous material is very well seen throughout the field, and throughout this you can make out the material. Again, more fields to show the signet appearance as well as the tubular. So these were CK7 positive. So what IHCs would you add? I'm just showing you a cytokeratin cell. So what would you be a thought process? So Parul said, and Niharika said, and everybody agrees. Poonam said that There are definitely signet ring cells in this. So do you think it's a signet ring cell adenocarcinoma? You definitely have these acinar and tubular structures, and then you have these signet ring cells with mixed or mucinous material. So do
It
you
was
think
my
it's
DD, sir. It was my
it
DD.
is
but
a, so you
yeah,
have to
it
keep
was
that
my
in
DD.
differential. Very
Yeah.
good.
But
So
it
you
was not my final diagnosis. I couldn't make
okay.
that.
Yes, that's fine. That's fine. So it does look like a signet ring. So you have to think that. So when do you think a urethra would have a signet ring cell carcinoma? Is it a common, rare?
I
Are we
think it's
discussing a
rare.
very rare case here?
Rare.
Never heard of that, sir. Yeah.
Never heard of that. So see, bladder can have signet ring cell, and I think Verma sir would agree that we can do see. But if you see a signet ring cell kind of carcinoma, which you think is a signet cell ring carcinoma, which is in the bladder or urethra, the first thought process which should come to your mind is whether it's a rectal cancer. Fine. So that is the thought process. It's a very adjacent organ. In a male, you don't have the uterus, you have a bladder which is adjacent to the rectum. So you should think of a colorectal cancer signet ring which is infiltrating the urethra or the bladder. That's the thought process. Fine. So for that, you should know what are the IHC profile of a rectal cancer, which is CK7, CK20, SAT-B2 positive. So we did all that, but we only found that CK7 was positive in this. Fine. So generally, it's not never a rectal cancer is not only CK7 positive. It's usually 20 also positive, definitely. Fine. I think, let me see if I can. This is again CK7 positive. You can see that the squamous cells are negative clearly here.
Yes.
And this all these signet appearing capillaries or whatever you want to call them positive, even these tubules are nicely positive. This is AMACAR. We did AMACAR. Now you should ask me why I did AMACAR.
Prostatic, sir.
So you should think. So like I said in my last lecture, AMACAR is not to be equated with prostate cancer. So AMACAR doesn't make it prostate cancer. You have to have absence of basal markers. He's a 55 male. He can definitely have a prostate cancer. So my point is, when you have an unusual morphology at any organ, you should think of whether it is a tumor which is coming from the adjacent organs. That's the thought process. Fine. And then you put up a profile, IHC profile, ancillary techniques to say whether it's a prostatic, rectal, or say if it's a female, it's a uterine or something like that. You understand? So that is important. The thought process is you have to know a good knowledge of anatomy, radiology. So you are in a very unique position as a pathologist. You have to collate all the data in this, and you have to give a thought process what it is. So AMACAR is strongly and granularly positive. How it is, it's in the tubules as well as those capillaries. And this is PAXate.
Okay.
Fine. This is a nice strong PAXate positivity in the nuclei of these cells. You see the tubular morphology of these cells, and you can see that they are nicely positive. This is not a female patient, so PAXate is generally we call it a misnomer as a Mullerian marker, but this is PAXate positive again to show you that this is PAXate positive. Fine. Even those single cells, those capillary size cells are positive. What you thought as capillaries or what you thought as signet rings are all PAXate positive. Again, PAXate nicely positive. You see this? These are your signet rings. See?
True, sir.
These
Yes,
are nicely positive for PAXate. All these are nicely. So what do we have positive? We have positive for PAXate. We have positivity for CK7, and we have positive for the we did a CK20 was negative. SAT-B2 was negative. We ruled out a rectal cancer. The radiology did not show anything in the rectum. We asked for those details from the patients. So my point is, you are a clinician. You have to ask questions. You have to look at radiology. You ask for serum tumor markers. The CEA was normal. The other tumor markers were normal in this. The problem is they look so malignant, they look so signety. So you did a MIB1 in this, and look at the MIB1. It is only marking some of the cells of these tubules. Actually, it is not marking any of these, most of these tubules. So it's a row proliferative index tumor, which is PAXate CK7 positive and which is AMACAR positive. This is what is called as a nephrogenic adenoma. Right? This is a rare case, rare morphology of this. So nephrogenic adenoma per se is not a rare thing to occur in the urogenital tract. It is usually related to instrumentation, long-standing inflammation, cystitis. They can all cause these nephrogenic formation of nephrogenic. Generally, you have this papillary, tubular, and tubulocystic appearance. But very rarely, along with this tubulocystic and tubular appearance, you can have signet-like appearance. So mind you, if it was purely signet, we have been really foxed. But thankfully, even in this morphology, you can see that several of them are actually tubules. You see, this is your clinching thing. This looks totally different. Looks very bland. There is no mitosis, no atypia. Although it does look a little hobnailing. it does make you remember about a clear cell adenocarcinoma of the ovary or say clear cell adenocarcinoma in general in the urogenital system. But there is no ATPI, there is no mitosis, and then these are accompanied by these very bland looking tubules. So this is not an uncommon tumor in the urogenital, which is nephrogenic adenoma, but there is a little different morphology. If you look at this, they have got this capillary-like appearance, but they have this thickened kind of basement membrane-like material which is there, which is little hyalinized. They look like thick endothelial cells or thick capillary walls, which is this, and that is very, very characteristic for picking up the finding of nephrogenic edema. Classically, they are Paxate positive. They are supposed to be renal tubular cells which are shed from renal tubules and get implanted in the bladder or in the urogenital tract. And this is a problematic case. See, if you call it signatoring, it's a completely high-grade malignant tumor. You understand? So you need to be aware of these things when you are diagnosing these cases. Thankfully, you have to look at more benign-looking areas, more classical areas, which are classically described in nephrogenic edema, which are these tubular capillaries and tubular or tubulocystic kind of appearance. They don't have nuclear ATPia, they don't have prominent nuclear, they don't have mitosis. And the classical IC is Paxate and CK7 positive and AMACA positivity. So this is a rare appearance of not an uncommon tumor in the urogenital tract. And I wanted to show you because this case was referred to as a signatoring cell adenocarcinoma. The referring clinician said that there is nothing in the rectum. When we called him up, they said the radiology is absolutely clear, and what it is a completely purely this thing. I think the patient had a history of instrumentation for some time, but that again, it's a referral case, so we don't have the details of this history. So this is a okay, Dr. Verma, you want to add something? Nephrogenic adenoma mimickers problematic issues in nephrogenic adenoma.
Nice case, right? So I think, yeah, so this is it's an important differential diagnosis. I think a couple of things I think I would like to make. I think one, when you talked about signatoring cells, yes. If you look at looks like those signatoring cells, many of them have got multiple nuclei.
Yes.
Right.
Yes.
So with signatoring cells, you would expect only one nucleus per signatoring cell. So that is a hint that these are not
Dr. Murli, there's an echo coming now. I think somebody has opened two systems. There's an echo. I request.
I'm getting an echo too.
Me too.
Maybe if you just mute, if everyone just mutes themselves.
Still echo there. Santosh, can you see?
No, sir.
Now, I think Murli, when you started, the echo started. When Santosh was speaking, there was no echo.
Okay. So I'm not sure why. I've got only one system open.
Maybe. I hope no students open two systems.
I think I'm getting an echo from you too.
Okay.
So there is. So I'm not. Yeah, I think there's somewhere there is an echo. I think we may probably have to.
Dr. Murli, can you do a favor? Can you rejoin?
Sorry, do you want me to leave and rejoin?
Yes.
Okay, let's try.
Thank you.
I can ask. Oh, ये सब पे echo हो रहा है क्या?
अभी echo बंद हो
गया. No, it's okay.
Yeah,
maybe Himalayan Jaishi. Did you think of nephrogenic adenoma? Have you seen a nephrogenic adenoma?
I have not seen it, but I read it after the case. So.
Yes, yeah. So this you should keep in mind because see, this is a differential between a benign and malignant. One is a signatoring carcinoma, which is highly malignant. It's a killer disease. Whereas nephrogenic adenoma is a reactive and a benign condition. Yeah, so you should know that. And generally, if you get a history of instrumentation, long-standing cystitis, stones, so some kind of inflammation in the bladder, radiation, or those things, you have to think of nephrogenic. So the clincher is the presence of these tubules. You should always look. These tubules look very banal and very benign. And that should help you in saying the whole lesion probably is benign. You understand? That's it. Yes, even though these cells look a little signatory and they look like signatoring, the whole thing is a benign condition. So you should go and read about this. The classical IHC is a Paxate and CK7 and AMACA. So that should be kept in mind.
Santosh, Dr. Murli is back.
Oh, he's back.
Let me try again. Is there an echo?
No, this is fine, sir.
Perfect.
Okay, perfect. Okay, I just want to make one, I think, important point with this. I think, Santosh, you mentioned earlier that choosing an immunopanel. When you choose an immunopanel, it should always be based on your morphological differential diagnosis. So what you do is you look at the morphology, come to a differential diagnosis, and then choose a panel which has got positives and negatives based on your morphology. This is an important example of that, because I think there's one marker here, I'm not sure whether it was done in this case, but which is high molecular weight cytokeratin, basal cell markers. About half of the basal nephrogenic adenomas will be negative for basal cell markers. So when you've got your differential diagnosis of prostate cancer versus nephrogenic adenoma, and if you just do a racemase and basal cell markers, it could be positive for AMACAR and negative for basal cell markers. So if you didn't consider the morphology of possibility of nephrogenic adenoma, you could go very, very seriously wrong. And it's not uncommon for patients with nephrogenic adenoma to have a history of prostate cancer, because these patients have had previous instrumentation.
Yes,
So
sir.
the previous instrumentation could be a TURP. The TURP had incidental prostate cancer. So now you got a patient with a history of prostate cancer and a gland-forming proliferation, which is positive for racemase, negative for basal cell markers. And you can see where you go wrong. And so the important thing there is the key marker that we would do certainly here, and I think I would recommend it, is NKX 3.1.
Yes.
So in the past, we used to depend on PSA and PSAP or PAPH, but today I think it's a transcription factor NKX 3.1, which is a very good prostatic marker and which would be negative in nephrogenic adenoma.
Yes, sir. Thank you for your comments, sir. I absolutely done. Yeah, that's very, very important. HMWCQ was not done in this because it turned out to be PAX8 and CK7 and AMACAR positive.
Santosh,
Uh-huh.
there is a question from an audience. Can I take it now?
Yeah, sure. Why not, sir?
Dr. Babita has a question. Dr. Babita, I am unmuting you. You can unmute yourself, Dr. Babita, and please ask a question.
Hello, Dr. Babita. How are you?
Bala Murugan is there. Bala Murugan, you have
Hi,
a question?
Bala. Hi, Bala. How are you?
No. I think you go ahead.
Yeah, fine.
There are two questions in the comment box.
Mm-hmm.
First question is, was the tumor was well circumscribed or not?
It wasn't very well circumscribed. To be very frank, it was not very well circumscribed. You can see on the morphology and it's not a very circumscribed kind of a thing. These are single looking cells, signety looking cells, which are just haywire and there's everything. But yeah, in general, it was not looking very infiltrative. We had small tissue bits which were fragmented. So circumscription was not which we were looking for in this. But yeah, I think the pinching thing in this is the presence of these tubules. So you should know that most of the nephrogenic adenomas will have a tubulopapillary kind of appearance, and that's very, very important to know about nephrogenic.
Santosh, if I can make a point.
Sure. Please, sir. Please go ahead, sir.
With nephrogenic adenoma, you have multiple patterns. You got the tubular pattern, the hobnail pattern, the cystic pattern, the papillary pattern. So you got all these various patterns, and each of these patterns can mimic something else. But there is almost no other proliferation that I know of which has a combination of all these patterns. So when you get a mixture of signet ring, tubular, papillary, cystic, hobnail, there's only one lesion that can cause it. And nephrogenic adenoma usually, again, the other name for nephrogenic adenoma was nephrogenic metaplasia. So it is not generally a well-circumscribed benign proliferation. It's often these sort of very haphazard glands within the stroma.
And so, one more question. What is the significance of hyaline material around the glands?
So that's a morphological thing which you see very commonly when you have this kind of capillary kind of appearance of this. I think I am not very sure of the EM findings of these, whether they are truly basement membrane. Maybe Burma sir can comment on that. Like this hyaline kind of thing, basement membrane material which you see on EM or something.
I'm not sure about the EM, but it's believed to be basement membrane
Yeah,
material. That's the general.
Yes.
I think, as Santosh said, it's a very useful morphological tip because there are very few other lesions which show this sort of tubular structure with the basement membrane material. So it's very useful morphologically.
And so last question, Dr. Babita is asking how to clearly differentiate gland from tubule. Example, in case of a ductal adenocarcinoma of prostate, sometimes confusion is there, whether it is a ductal or acinar.
No. I think there is no confusion between a ductal and SNR adenocarcinoma of the prostate. I am assuming she is Dr. Babita is asking about prostate. A ductal adenocarcinoma looks something like a tubular adenoma or a tubulovillous adenoma of the colon. So something which looks like a tubulovillous adenoma with long, slender villi kind of appearance, with long, slender papillary proliferation, large ductal kind of pattern. That's when you call it a ductal adenocarcinoma. SNI are small glands which you see in typical prostate conventional cancer. Yeah, Verma sir, yeah, please comment, sir.
I think there's one other. It's an important differential diagnosis. It's a rare differential diagnosis, but it's an important one. There is a type of clear cell carcinoma that looks exactly like nephrogenic adenoma. It looks very much like nephrogenic adenoma. Very easy to mistake it for nephrogenic adenoma. The key thing here is, again, going back to how Santosh started this meeting, the clinical bit of it. Nephrogenic adenoma is common in 90% of nephrogenic adenoma are in males. Clear cell adenocarcinoma, almost in all of them are in females. So be very careful before diagnosing clear cell adenocarcinoma in a male. It's possible, it can happen, but very, very rare. The second point is if you see mitosis. So so the point I'm making here, I think it's to reiterate and emphasize the point that Santosh made earlier, that when you start looking at a case, if you got a case of what looks like nephrogenic adenoma in a female, just look at it a little bit more carefully. So there, if you got mitosis, think about the possibility of clear cell carcinoma. So there is an entity, I don't want to scare you. What you don't want is to spend half an hour on every simple, obvious nephrogenic adenoma because you're worried about clear cell carcinoma. But there are, the one situation that you really have to worry about this rare entity is if you see what looks like a nephrogenic adenoma in a diverticular biopsy. Nobody really that these nephrogenic adenoma like clear cell carcinomas are more common in diverticulae of the bladder or the urethra. So if you get a biopsy from a female in a diverticulum that looks like a nephrogenic adenoma, that is one that you certainly want to look more carefully for. It doesn't mean that you go and you don't necessarily have to do a MIB1 or a Ki67, but look at it a little bit more carefully. And then if you see some mitosis, if you're seeing some atypical features, then you may want to go and do a MIB1.
Thank you, sir. Thank you.
Sir, one last question just to pop up in here. How will you explain a signet cell who look malignant and from a real signet cell of a rectum carcinoma?
So it was a serious consideration that this was signet ring. So it was referred to as a signet ring cell adenocarcinoma of rectum infiltrating the urethra. It was a serious consideration. But the morphology of this basement membrane thickening hyaline material and the presence of those banal looking tubules with hobnailing, which is characteristic of nephrogenic adenoma. Once you see that, you know that there is a hint of nephrogenic adenoma. So I will not contest anybody who says that they look signet ring. They do look like signet ring cells. And we did CK20, we did SATB2 and all that. We did it to sort of refute a diagnosis of that because the referral diagnosis was a signet ring cell. So the panel was done, but then the morphology is signet, and we should keep this in mind always. Understand? Yeah.
Again, I think it is a company it keeps, isn't it? You got signet ring cells can look like signet ring carcinoma, but you got the tubules and the cystically dilated glands. Those don't look like rectal cancer.
Yeah, I think we'll go to next case, Dr. Tala.
Yeah, no, so please continue.
The second case was a 53-year-old female. She had a history of hysterectomy. So remember, there is a history of hysterectomy for multiple fibroids. That's what the history we got. Hematuria for 10 days, urine cytology was positive for malignant cells. Somewhere else, TURBT was done, and it was called as invasive TCC with invasion of muscularis propria and lymphatic invasion. And on CCT abdomen, the report which had come was there was a neoplastic lesion in the anterior wall of the bladder with pelvic and retroperitoneal lymphadenopathy. This is the TURBT chip. As you all know, TURBT, we just saw that they go through the urethra, they go into the bladder. They use a loop of current or loop of current which to cauterize and cut through this tumor in the bladder, and that's what you get, a very fragmented kind of tissue in the TURBT, which has a lot of cautery artifacts which you can see very prominently at the periphery of these tissue bits here. And then you can see something here, you can see something here. So they are blue looking areas, and then you can see the lamina propria blood vessels, which are very clearly seen in this low power. Coming to a little more higher power, you can see that there's looking very busy, very cellular looking areas, a large nested kind of pattern, and then there you have some retraction artifacts here, which is prominent here and as well as here. Definitely you can see this.
Yes, sir.
More higher areas to show that this is how one of the TURBT chips looked like. You have this very floating looking chunks of tumor or bits of tumor which are within large retraction spaces, and within the same large lacunar spaces you have multiple bits of these floating
Nest
kind
or
of
aggregates.
nested or aggregates of cells which are floating here. Fine. So Jayshree, you want to say more about this?
Sir, I could able to see micropapillary architecture or that.
So you call them micropapillary? So how is a papillary different from a micropapillary? Anybody else? Ruchika, you want to?
Yeah, sure.
I can see a nested pattern.
Okay.
Like, where there is no fibrovascular core.
Okay. We'll go to more higher power. So this is how it looked.
Yes, sir.
So you have this floating kind of papillae, you want to say, with no fibrovascular cores. There is some lumina in between.
Yes,
and then
sir,
they appear to be present within large lacunar spaces, multiple these bits of whatever you want to call it, malignant urothelium or whatever it is within this. And then there are lymphocytes all around this here, which you can see. This is from a different case, but had similar morphology. Again, you have these floating kind of micropapillae. Parul, you agree?
Yes, sir, definitely. In the history also, they have said they have suspicious of lymphovascular invasion.
Okay.
But I think there was no this is not lymphovascular invasion. This is due to the retraction of the tumor caused by
You
the
see
tumor.
the size of papillae, how variable they are. Some are large, some are these very
variable.
small,
Yes, sir.
floating, very variable kind of.
Definitely, sir. They are
micropapillae
variable.
here.
Yes, sir.
Yeah. Fine.
They are more in small nests and aggregates, I would say.
Yes. Verma sir, you want to correct them in their description? Anything?
Yeah, perfect.
Yeah,
As you very rightly said, you got these spaces with multiple of these small papillary structures.
Yes.
So, but this particular form of carcinoma is often associated with lymphovascular invasion.
Yes.
Parul is absolutely right that what you're seeing here is not lymphovascular invasion, but if you look hard enough, you often find lymphovascular invasion too.
Yes, sir. Okay.
So you thought these were lymphovascular emboli, or these were floating micropapillae?
Floating micropapillae.
Niharika, you thought they were LVSI in this?
No, sir. No, sir, micropapillae.
These are all micropapillae. So have you seen this kind of morphology in urothelial cancer? No.
Yeah, I remember one case.
Variant of urothelial cancer.
Okay. So we'll come to the terminology. So sometimes these micropapillae can have this kind of morphology in which they have kind of luminal kind of appearance, and they're called ring forms. So they look like rings.
Ring forms.
Called ring forms. So this is what you call as ring forms, which can occur. You can very well say that these retraction artifacts are within the lamina propria. So it's a lamina propria invasive tumor, which is very clearly seen. So what do you think the diagnosis is? I think you know what the diagnosis is micropapillary. In a female who has had hysterectomy for query what cause, we don't know whether ovary was removed. You have to keep all this as a possibility in females also. So my point is, especially we have seen some metastatic breast cancers, usually lobular, which can sometimes have these aggregates within the lamina and can look like urothelial cancer. And mind you, a breast cancer is also GATA3 positive along with urothelial. So you have to keep these things in mind. This is again the same pictures to show you how these floating papillae look within the large lacunar spaces. So if you look at each lacunar space, empty space, there are multiple floating. So that is the characteristic feature of micropapillary urothelial. Presences of this variably sized floating papillae within large single lacunar spaces, which look like retraction artifacts. And this is how they look. Sometimes you may have multinucleated giant cells which start looking almost like trophoblastic appearance, and that can be sometimes if you employ a beta HCG, and you may find that these are beta HCG positive, and that's a different kind of a subtype which is called a trophoblastic subtype. This is
can
the
you please
ring form.
okay. Can you please go back to previous slide, sir?
Which one?
This one, yeah, sir. When I saw this case, I directly jumped to this slide, sir. And my DD one was neuroendocrine tumor.
Oh yeah, that's fine. That's fine. So you thought that these were vascular kind of septae with vascular and these kind of.
Yes, sir.
Generally a carcinoid or a neuroendocrine tumor in the bladder is not a very common occurrence. What you get in bladder is usually a small cell carcinoma of the bladder. That is again always almost associated with high-grade urothelial carcinoma in most of the cases. In neuroendocrine tumors, you may find these retraction kind of pins. You are perfectly right, but the nuclear features are very smudgy and dirty looking in this, and they don't comply with a carcinoid kind of appearance, I'll say. That's important. Yeah, fine.
Yes,
Sorry,
thank you.
back to history also, there was one line where you have written calcified nodule, something RUL. Is that for the lung?
Right upper
I think that was a right upper lobe of the lung. Yeah.
Right
Yeah,
upper.
so
Yeah.
there's another
Many of these micropapillary have
contradicting
nodal metastasis and distant metastasis at present because these are aggressive kind of subtypes of bladder cancer. So again, this picture shows you the ring kind of forms, lamina propria invasive tumors, and again the floating micropapillary. So the diagnosis is micropapillary urothelial cancer. These are known to be HER2 positive in about 60-70% cases. Dr. Verma, do you do HER2 in all cases of micropapillary?
No, we don't.
You
No,
don't.
generally, it's usually a morphological diagnosis.
Morphological. But does your clinician or oncologist insist that you should do HER2?
No.
And in your practice, do
No,
they
because they treat it as like any other urothelial carcinoma, except I think I'll let you finish, and then we'll talk a little bit about clinical utility later.
So this is what micropapillary, they have a striking male predominance, and they are generally associated with more dismal. Although recent studies are again saying that they are stage to stage balanced with high-grade urothelial cancer. But many of the micropapillary urothelial, once you give it in the report, especially if they are more than 50% of the tumor of high grade, they would likely to have nodal metastasis, and many of the clinicians get alarmed on getting this report of micropapillary urothelial cancer, and they may be candidates for early cystectomy. So even if you have a LP, lamina propria invasive tumor, and not a muscle invasive cancer, these patients may be candidates for an early cystectomy, and that's the importance of picking up these variants. I think I'll skip this. I'll just come to that. Why do you want to know about this divergent differentiation? So all these subtypes, the micropapillary squamous, these are called as, earlier used to be called as variant histology, but now they are called as subtypes of urothelial cancer. As high as 60 to 80% of them are muscle invasive present. So that's the importance. That's the importance of picking up these different histologies, because many of them, majority of them are muscle invasive presentation. And as pathologists, we tend to miss this histology and they are under recognized. So we need to be aware of this. So what are the different subtypes? These are the ones: squamous, micropapillary, plasmacytoid, adenocarcinoma, nested. And squamous are easy to diagnose. The importance of these are that the squamous one is responsive to PD-L1 therapy, especially in the metastatic setting. That is important. A micropapillary is positive for GATA3. They may be positive for CK56 and CRB2, as I've already told. They have advanced stage at presentation, and an early cystectomy may be offered to these patients, even if they are not muscle invasive cancers. And that's the importance. Nested variant looks extremely bland. They may have this kind of microcystic appearance, very, very bland, low-grade kind of nuclei. But when you do IHCs and we look at morphology carefully, they may be muscle invasive in many of these cases. So that's the importance of this nested variant. Plasmacytoid look very much like plasma cells, very, very sort of separated from each other, because they lose E-cadherin. There is loss of E-cadherin, so they are separated. They are not bound to each other. They are extremely invasive, and they have strange pattern of peritoneal metastasis to the gut wall, metastasis to the peritoneum, metastasis to the abdominal wall. There's a very strange kind of presentations of plasmacytoid variant, plasmacytoid subtype of urothelial cancer. Small cell, we all know, in any organ, small cell carcinoma is a very aggressive subtype, and they are treated with chemotherapy, which is mostly etoposide based chemotherapy. And if you do a synaptochroma, most of them would be positive in this setting. So the morphological is the presence of this apoptosis and the nuclear molding, which is seen even in similar to lung cancer, what you see. So I'll end that. Dr. Verma, you want to add something on this?
I think just two minor points. One is, I think, one other reason why it's useful to document these. Another reason why it's useful to document these variant or subtype morphologies is that if the patient later comes back with metastasis, right? The problem is if you got this morphology in a lymph node, urothelial carcinoma is not what you're thinking about. So it is helpful for the pathologist who's got this 3 years down the line to know that the original tumor had a micropapillary pattern, and so this is likely to be metastasis from the bladder rather than a new primary. The other point is, I think there is a variant of micropapillary where it is TA, non-invasive.
Yes,
So you got
surface
only on the
micropapillary.
surface, you got a micropapillary pattern. It looks very much like a borderline tumor of the ovary. That tumor does not have the same bad prognosis that invasive micropapillary has. And so the current recommendation is not to call it micropapillary carcinoma unless it is T1. So if you got only the surface, which is showing a micropapillary architecture, you can call it micropapillary pattern, or you describe micropapillary in your description, but don't call it a micropapillary subtype. You call it a micropapillary subtype only if that is invading the lamina propria.
Yeah. Thank you, sir. Thank you for your comment.
And so two questions are there regarding this case.
Okay.
Does the status of HER2 news has any prognostic value in this case?
I'm not very sure. There are conflicting reports about that. So we have had a couple of cases in which the HER2 was 3+ by the definition of breast kind of HER2 reporting. And in those couple of cases, they did an amplification FISH also, and they found it amplified also. But they gave Herceptin to those patients. It was a metastatic case. The utility was very limited in those cases. So our experience is limited in that. I don't know, Dr. Verma, any Verma sir, do you give Herceptin to these patients in your setting?
I'm not aware of them using Herceptin here.
Yeah.
So here they will be treated like urothelial carcinoma,
Yes,
it will be cisplatin chemotherapy and surgery and cisplatin chemotherapy.
Yes. So currently, quote unquote, this is not very sure. Though HER2 is done, maybe done, but I don't think it implies that they may be given Herceptin and they will respond to Herceptin.
Okay, sir. So one last question: does the different subtype of urothelial carcinoma has any prognostic significance?
Yes. So most, like I said, many of these subtypes are actually muscle invasive at presentation. There are different studies which quote it from 40% to 70%, 80% maybe muscle invasive present. And once you have a muscle invasive cancer, the treatment is either a radical cystectomy, cystoprostatectomy, or a neoadjuvant chemotherapy followed by cystectomy in these patients. Whereas if they are non-invasive, even in the setting of micropapillary, and sometimes these patients may be candidates for early cystectomy. So the point is that these are aggressive subtypes. Most of them are aggressive. The chances of muscle invasion in these tumors is very high, and the clinician looks at them and tries to treat them a little differently from what we do at conventional urothelial cancers.
Thank you, sir. Please continue.
Yeah. Shall I move to the third case? Yeah. So third case is a simpler one. It's a 68-year-old male patient with lower urinary tract symptoms, and PSA was done, and PSA was 11.2, so it is more than 10. The clinician definitely gets worried when the PSA is more than 4, and definitely more worried when it is more than 10. So this is so they went ahead and did a 12-core biopsy. I'll go into the slides. So Niharika and Poonam.
Yes, sir. Sir, in this prostate biopsy core, we can appreciate irregular shaped separate non-fused glands.
Non-fused glands, very good. So they are separate looking glands, very good.
Yes, sir. And sir, there is so we can also appreciate there is absence of the basal layer.
Wow, you can see the basal layers. You can see the absence of basal layers on morphology.
Yes, sir.
Niharika, we had a class day before yesterday, and I strongly suggested not to try and pick up basal cells and not to comment on basal cells. Not to, if you're really thinking that these small glands are malignant, you know that they will lose the basal cells. So you have to be careful when you see. I'm not saying that you should not look for them, but the point is, if there is an iota of suspicion in small glands, rigid looking glands, you should think of doing IHCs. Any difference? You want to add something? Poonam, Himali, yeah. Parul, Himali, Jayashree, you are anybody's free to pitch in. Please don't wait for my prompt.
So, in this true-cut biopsy of prostate, so we can see that the majority glands are regular. They are well formed, majority.
But you tell me first thing, Parul, are they large glands, or do they look normal or not? We had a class day before yesterday. Are they the large gland pattern with the luminal convolutions? Are they looking normal?
No,
No,
sir.
no, sir. They are not
Everybody
normal.
agrees to one thing, that they don't look like normal large glands of the prostate. They don't have that foamy or the clear looking cytoplasm of the normal looking glands of the prostate. That is not there. Fine.
Yes.
So there is some abnormality. You agree to that?
Yes, sir.
Yes, sir.
Very good. Yes, please go ahead.
Yes. Mostly the glands, they are well formed. Like they have regular shape. They are not distorted or fused, or they have any cribriform appearance. They are mostly they are well formed. But there are few glands which are like they are fused also, and they have a little bit of distortion also.
Okay.
So I would go with that, sir. Okay, it is definitely a, what I have thought, it is a tumor, not
Okay.
a benign condition, sir.
Okay. Okay. Any difference of opinion? Himali, Poonam?
No, sir. Sir, we are able to draw an imaginary circle around the glands.
Each of the glands. Very good.
That is normal one. But on the other slide, we can also see some of the glands have got fused. I'm not able to draw that circle.
Okay. What about these cells you see here?
Lymphocytic.
Yes, lymphocytic.
Chronic inflammatory.
They are chronic inflammatory cells. So, so they are chronic inflammatory, and these are your glands which are separated out. There are no fusion of glands much, so they are separated out. Do you see the stroma here? A little bit of stroma. More
Yes,
appreciated
Yes,
here.
sir.
This in this slide.
Fused glands.
Yes, sir. Yes.
Do you think these are fused glands?
Yes.
Okay.
Like, this is a
Are
fused
they are
gland.
they pale looking glands, or are they blue looking glands? Let me put the question like this. Are they looking? So you said they are not normal glands. Fine. They are not large normal
Okay.
glands with foamy or clear cytoplasm. Do you see the cytoplasm of the cell? Is it a prominent cytoplasm? Do you see prominent nucleoli at this power or this power?
No.
No, sir.
Do you see a little mixoidy or a early desmoplastic
Yes.
kind of appearance of the
Yes,
stroma?
Yes.
Yes.
Yes, sir.
There is more
And
kind of nuclear hyperchromasia as
hyperchromasia. So hyperchromasia and prominent nucleoli will not go hand in hand in general. No? In
true,
general,
sir. True.
if the nuclei hyperchromatic, then you can
We
hardly
won't
find
see.
the nucleoli.
Yeah,
No? Yeah.
we won't see.
And that's it. Fine. Fine. Verma sir, you want to prompt them?
Sorry, couple of things. If you look, what do the glands look like? Do they look pale or do they look dark?
Dark.
Dark. Why
dark.
do they look dark?
More likely due to some nuclear hyperchromasia.
Is it just because the nuclear hyperchromasia? Santosh, if you go one power higher.
Yes. Yes.
So the reason they are looking dark is because the cells have very little cytoplasm, right? So we talk about atrophy in the prostate. So when you talk about atrophy or an atrophic pattern, you can get prostate cancers with an atrophic pattern. So what do we mean by atrophy?
That the stroma to gland ratio is less. The gland to stroma ratio is less.
Sir,
So
cytoplasm
not in the
lateral and
prostate.
apical
So in the
cytoplasm.
prostate, we've got a very specific definition for what we mean by atrophy. Yeah, sorry.
Sir, there is a decrease in the lateral and apical cytoplasm
Yeah, which cytoplasm?
of the
So you got,
of the
where
cells lining
in
the
prostate glands, there is two cytoplasm. There's what we call the lateral cytoplasm on the side of the nucleus and the apical cytoplasm. That is the cytoplasm between the nucleus and the lumen, right? In atrophy, it is the cytoplasm between the lumen and the nucleus, which is lost. So the nucleus reaches the lumen. So if you look at normal prostate glands, the nuclei of the normal prostate gland would not reach the lumen of the gland. While here, many of these are reaching the lumen. So there is another type of atrophy, which is called partial atrophy. That looks very pale because it's got a lot of cytoplasm, but that is lateral cytoplasm. Again, there is no apical cytoplasm. So in this case, so the first thing that should strike you here is that it's a very blue proliferation where the nuclei are going to the lumen. And so you have to be thinking about atrophy. Now, when you think about atrophy, this might be benign atrophy, or this could be atrophic variant of prostate cancer. So you got prostate cancer, which looks atrophic. The other point I would like to make is you talked about the stromal reaction. Unlike other cancers, in all other tumors, if you see a desmoplastic reaction, you take notice and think that desmoplasia suggests malignancy. In the prostate, it is opposite. ordinary acinar type prostate cancer does not produce a desmoplastic reaction. There is no stromal reaction with acinar prostate cancer. Ductal prostate cancer can have. So if you see a stromal reaction and you're thinking about prostate cancer, think about two other possibilities. One possibility is that it's not prostate cancer at all and it's something benign, that it's a benign proliferation, or that it's a urothelial carcinoma, which will have a desmoplastic reaction. Ductal type of adenocarcinoma of the prostate can have a stromal reaction. So in this thing, two features that should, or three features really, that should make you question that this may not be prostate cancer is the atrophic appearance, the desmoplastic or the stromal reaction, and the lymphocytic, that you got lymphocytic infiltration in the background related to these glands. These three things are unusual in prostate. They can happen. It doesn't exclude prostate cancer, but that's the sort of thing that makes you feel that you would at least want to do immunohistochemistry. Santosh, all yours.
Yes, yeah. And more, they're still in a family. They all look like they are in a family, and there are no glands which are running away from the family. There are no orphan-looking glands. They're still in a kind of a big lobular architecture, although you cannot comment on a lobular pattern architecture on a biopsy in many cases. But like sir said, the blue-looking pattern, the presence of inflammation in these foci, which is very uncommon in prostate cancer, should make you think that is it atrophy. I totally agree with Parul and Niharika and Poonam and all that. They are looking like glands which are small. They have rigid lumen. They are very rounded, small. So you do think that this might be a pattern 3 of prostate cancer. But then when you think of prostate cancer, you should always take into consideration that desmoplasia and stromal reaction doesn't occur. Inflammation doesn't occur. They usually have glands which are away from their family. And that's when you start seeing. Obviously, the cytological features of presence of nucleoli. And the most important thing is that you have to use your IHCs. So this is a typical indication where you would want to use your IHCs. We have discussed this in previous class where we would use IHCs, and it has got real implications. Is there help? And we know that the absence of basal markers helps in diagnosing prostate cancer. And this is a basic panel which we use. I have not included other. Some people can use CK720 and all that, but I think high molecular weight keratin and P63 are the most important marker, more important than AMACAR in diagnosis of suspicious focus of prostate to designate and call them as prostate cancer. I think we discussed this at length in last class, Verma sir. But I wanted to put this case specifically because I knew that after the previous class, they would all think that these are well-formed glands and separate. So this is a pattern 3 prostate cancer. But when something looks blue under the microscope in a prostate, in a family-like fashion where the glands are huddled together with stromal reaction, with inflammation, you should always think of atrophy. Obviously, like sir said, this might still be an atrophic prostate cancer. In those foci, you will have absence of basal layer. You will have prominent nucleoli. Those features will help you in confirming a diagnosis of prostate cancer. But till then, morphologically, you should think that these are atrophic foci in the prostate. So HMWCK is nicely positive, as you can see. 63 was positive in these foci. Mind you, P63 might not be so much. There may be few cells which are P63, but any number of even few P63 nuclei in this whole focus would make the whole focus as benign, because the morphologically they all look similar. So even any presence of basal cells makes the whole focus as benign in this. This is P63 and higher power. Quickly going on to a little bit of benign mimickers, you should know that the small gland pattern is seen in atrophy. Partial atrophy has already been spoken by sir. Can have seminal vesicles which can look very, very much like this. Copper's glands and other reactive conditions can look like this. This is a paraganglioma, a paraganglion within the prostate. Sometimes this is not uncommon. They have this foamy looking appearance. They look like as if they form some glandular pattern. If you start looking at nucleoli, the ganglion cells have prominent nucleoli, so you are likely to mistake them. But sometimes you are easily able to pick up the Schwann kind or the nerve bundle kind of morphology within them, and then you're sure that you're looking. And the cytoplasm is usually very amphiphilic in appearance of this paraganglion. This is a seminal vesicle which may be inadvertently sampled in a prostate biopsy. The presence of lipofuscin pigment is helpful, but in a young patient, you may not have this wear and tear pigment, and that's when you look at these morphology of the cells, they look pretty bizarre. So generally, a prostate gland-forming tumor will not have bizarre-looking nuclei. These are called monstrous nuclei, which are generally and commonly present in native seminal vesicles. So even in the absence of these lipofuscin pigment, you may be able to say that these are seminal vesicle epithelium. Corpus glands are very characteristic. These have got this wispy kind of appearance, very, very lobulated appearance, and they are huddled together and they look very characteristic. Atypical adenomatous hyperplasia, I don't know whether we use that term, not Verma sir. Do you use it in UK?
It is generally recommended not to use this term because there's nothing atypical about it, because the problem is atypical might scare people. So
exactly.
Preference
so we should not use
the word adenosis.
Yeah. So they use adenosis. Many of the lymphocytes we had discussed in last that lymphocytes can have halo around them. They can start forming vague acinar-like structures, and you should always keep in mind that a pattern 5 prostate cancer query always can mimic sheets of lymphocytes, and you have to be careful and always have this in the back of your mind and use your IHC. Xanthogranulomatous prostatitis can look very much like a pattern 5 cancer, and you should always have the awareness of this presence of these. Again, to reiterate, P63 IHC and HMWCK IHC, absence of these basal markers is very important to diagnose prostate cancer, more than the circumferential expression of the Amakar staining, which is also used as a panel.
So can I just make
one? Please.
Yeah, I think one pitfall to be aware of is there's a variant of prostate cancer called P63 positive prostate cancer, and P63 positive prostate cancer is often has an atrophic pattern. It's commonly has an atrophic pattern. So when you get an atrophic tumor like this, or an atrophic proliferation, don't do only P63. Always do a high molecular weight cytokeratin and a P63, because if you do only P63, these could show a very nice P63 positivity, and that might mislead you to misdiagnosing a P63 positive cancer as benign atrophy.
Dr. Tala, any questions on this?
No, sir. Please continue.
Yeah. So I'll quickly move on to the 4th case, and we'll wrap up here after this. This is case number 4. It's a more straightforward. This is a 30-year-old male patient with scrotal swelling since 7 months. On examination, there is loss of testicular sensation, and the testicular mass is 7 into 6 centimeters. So is it a testicular tumor? Loss of sensation, 38 male, young patient. What is your thought process, Himali and Jayashree?
Yes, so it can be a testicular tumor. The age goes with that, 38 years.
Okay. So a youngish patient with scrotal swelling, it's a testicular mass. There is loss of testicular sensation. So Himali, you say that it's a testicular tumor. What about others? What is the first thing you would want to know in this patient? So when you're thinking of testicular tumor, what comes to you? In a young patient, testicular tumor? What are the possibilities? Anybody? Niharika? Ruchika? Parul?
Sir, I will go with germ cell tumor.
Okay.
Yeah.
So you would think, so if you think of a testicular tumor in a young patient, the first thought process, the first, second, and third thought process should always be a germ cell tumor. You should always think that this is the commonest tumor, and these are the things which occur commonly. Very rarely you can get sex-cord stromal tumors, but you have to think that first possibility is a germ cell tumor. So for a germ cell tumor, what would you need actually?
Tumor markers are very important for that.
Okay. So what tumor markers do you think of?
We will go for alpha fetoprotein, beta HCG levels.
You tell me out of this, what is your choice? What is your choice? What is the multiple choice?
Go for third
option.
Everybody agrees?
Yes,
Jason, you agree? Poonam,
Yes.
you agree? Everybody agrees?
Yes, sir.
Yes.
Okay. So, fine. So calcitonin definitely not. AST, LT not. So LDH, AFP, and beta HCG. Verma sir, you want to add something here? Testicular mass.
The absolutely critical thing is to know the serum markers, and I think we'll talk about it a little bit at the end. How that can be actually more important than the histology.
Yes. So Niharika, you want to tell why AFP and beta HCG are important?
Sir, yolk sac tumor.
Sorry. Anybody else?
Yolk sac tumor, she said.
Yolk sac tumor. AFP for yolk sac tumor, beta HCG for?
For germ cell tumors and choriocarcinoma.
Choriocarcinoma. So very high beta HCG seen in choriocarcinomas. Moderate
Seminoma.
elevations can be seen in embryonal and sometimes very, very rarely in seminomas, because seminomas can have syncytial trophoblasts which secrete beta HCG. You can have in the range of hundreds up to a bit of 1,000. You can have beta HCG even in pure seminomas. So these markers, LDH is very non-specific. Any tumor which is having high turnover,
dysgerminoma.
yeah. So seminoma, dysgerminoma will have high risk. Even non-seminomatous germ cell tumors. So germ cell tumors basically are categorized into seminomas and non-seminomatous germ cell tumors. I'll leave it to Verma sir to later explain what is important. So what is the most common germ cell tumor of the testis?
Seminoma.
All 6 of you agree?
Yes, sir.
Seminoma.
Yeah, and what will be the markers, serum tumor markers in seminoma?
AFP levels in
OC4,
beta
SALK4,
No. That is IHC, Ruchika. You are directly jumping to IHC. This is
LDH.
what I'm asking. Serum tumor markers.
Okay, serum. LDH.
LDH won't, I think so.
LDH. So maybe LDH. Yeah. Verma sir, yeah, please add.
Just a point. When you say most common tumor, the important thing in testicular tumor is the age. The most common tumor in adolescents is different from the most common tumor in a 40-year-old. So if you got a patient of around 40, 50-year-old, the most common tumor would be seminoma. The most common tumor in a teenager would be a non-seminoma. So seminomas are very unusual in young. So if you it's a teenager, then think about non-seminoma. If it is a 40, 45-year-old, think about a classical seminoma. If it is a patient of 70 plus, then think about lymphoma or spermatocytic tumor. So that's basically where the age kind of helps you.
So this is a whole mount and a scanned slide of this tumor. You can see that even this flavor, you can see that there are hyaline septae which are running through this. This is the tumor is involving the spermatic cord. You can see the vas deferens here. It is involving the cord. And this is the higher magnification. What do you see here? Do you see a lot of crushed and smudged nuclei here?
Yes.
Yes, sir.
Everybody agrees?
True.
And then you see a lot of pink background, which is the septae and the stromal tissue, which is there. And then you have these cells again, which is showing some smudginess here. A better power to show the picture of this tumor? Anybody wants to describe? Yeah, maybe Poonam can describe this.
So we can see the septa, and both side of it we can see this tumor cells, and it can be tumor cells can be seen invading the septa.
The tumor cells are showing they're aggressive looking tumor cells, and the fibrous septa are infiltrated with lymphocytes. Even the
most importantly, the tumor cells, they have clear cytoplasm.
Clear cytoplasm.
Okay, so you can appreciate clear cytoplasm. Very good. Okay.
And
So
moreover,
you
the
think there is
septa
cytoplasm? I think even at this power, you can make out the prominent nucleoli.
Yes, sir.
And even at a low power, you can see that if you look at this, cell nuclei look a little vesicular to opened up chromatin and prominent nucleoli, and then you have this sprinkling of lymphocytes here and there.
True.
Right? Yeah, so that is important to make out in this. You see, these are the lymphocytes, and then these are the tumor cells, and these are the septae or the stromal tissue where you see sprinkling of the lymphocytes throughout this tumor. This is more higher power, again showing you similar morphology, very opened up chromatin, prominent nucleoli. So germ cells in general, all germ cells will have prominent nucleoli. You understand? Other tumors which are prominent nucleoli, you know very well, like melanomas and nasopharyngeal carcinomas. This is a classical teaching of prominent nucleoli. So this is how they look. But there are other areas where they look very dirty and smudgy. They throw you off totally. Verma sir, you agree? They look very smudgy and dirty looking at places. Yeah. So
Sir, when do we call that overlapping of nuclei then, sir?
Overlapping of nuclei in what sense? So see, if any tumor has got a lot of cytoplasm, there is very less chance that the nuclei will overlap. You understand? It's only the overlapping of nuclei comes when there is obviously it's a very, very aggressive and fast growing tumor where there is no contact inhibition, so the cells pile up on each other, and that's when you see. But in general, when you have a lot of cytoplasm in any tumor, do you see this? What are these? Small aggregates you see here, pink looking areas. These are not lymphocytes. There are lymphocytes which are
apoptotic bodies.
No. So these pink looking areas, if you look at the nuclei, they look vague. They are vague granulomas. This is just to show that seminomas. So this is everybody agrees this is a seminoma. I think everybody would agree.
Yes, sir.
Probably because this has got typical findings of a malignant tumor in the testis in a young patient with septae showing lymphocytes and a prominent nucleus. So this is a germ cell tumor and the classical morphology of a seminoma, although there is some smudginess of the nuclei, which makes you think is that there is embryonal carcinoma or not. But then there are some granulomas. The point of showing you this is that sometimes these granulomas may be overwhelming, and Verma sir will vouch for it. He has seen it more than maybe 20, 50 times. You must have seen granulomas totally overwhelming a seminoma to the extent that you have to really hunt for the seminoma cells. So the idea is that if you see granulomas in a young male testis, you should always try and hunt. This is a typical classical case which is showing some granulomas. Approximately 40% of 30 to 40% of seminomas can show some granulomas, granulomatous reaction. It is important. So I don't think we did much IHCs in this. Maybe a couple of them like OCT4, Niharika and others were saying that OCT4 and D240 and CKIT are classically seen. But when you see this kind of morphology, you are pretty much sure that you are dealing, especially if your tumor markers like AFP and beta HCG are not raised. This is just a picture to show how you gross the testis. It is important that you take the tumor, you take the sections away from the tumor, because you will see germ cell neoplasia in situ in about 90% of cases, which helps you understand and confirm that this is indeed a germ cell tumor, especially if you have very limited section of the tumor. A testicular section from the normal testis which shows GCNS can help you in diagnosing the germ cell tumor. To take sections from epidermis and the base of the cord and the cut section of the cord, it is important. So these are the basic things which you see in a microscopic pathology report in a GCT. A couple of pictures to show non-seminomatous changes. This is a non-seminomatous germ cell tumor showing teratomatous cartilage and epithelium. Yolk sac pattern, typical classical microcystic kind of pattern, or the endodermal sinus pattern. You can have rhabdomyomatous elements, which are again banal and benign looking things. You may have very spindle looking stroma, which you call as immature mesenchyme, which has got no significance. Immature teratoma itself has immature neuroepithelium has also lost its significance in most of the testicular pathology because they are almost always part of a NSGCT spectrum. I think I'll just thank and end my slide seminar by acknowledging Verma sir. Sir, thank you for taking time out during Christmas holidays. It's been a pleasure to have you here. I would also like to thank my resident Dr. Ashish. The nephrogenic pictures are from one of his presentations, and Dr. Akash, who is a consultant at Karkavan, who was my first thesis student and colleague, is now a colleague in many ways. I wish you a very, very happy New Year to everyone.
Happy New Year, sir. Happy New Year.
Thank you, sir.
Thank you, sir.
Any additions, Verma sir, on this?
I think I'd like to make just a couple of points, Santosh, if you don't mind. So the first one is about GCNIS. I know the guidelines say that it's very important to document GCNIS because if you don't see GCNIS, that would raise the possibility that this is not a germ cell tumor. So the negativity is almost more important. In my experience, I don't think it's particularly useful because the differential diagnosis between germ cell and non-germ cell is so important that if I've got any doubt that this is not a germ cell tumor, I'm going to do immunohistochemistry on the tumor rather than depend on the presence or absence of GCNIS. So the point I'm making here is, by all means, look for GCNIS, but don't use GCNIS as your criterion in a difficult case. There is a pattern of where you get these clear seminiferous cells, which can look very much like GCNIS. So that is one pitfall. And finally, as far as the clinicians are concerned, it's the serum markers that are critical. So if you've got a patient with a raised serum AFP, and the path report is pure seminoma, they are going to manage this patient as a non-seminoma. So even though you have not seen any embryonal or yolk sac element, as far as the treatment goes, they are still going to treat this patient as a non-seminoma. So especially if the HCG has fallen after the orchidectomy, suggesting that the source of HCG was the testis rather than any like the liver or anything else, and if the AFP is rising after orchidectomy, which suggests that there is metastasis, right? So the point I'm making here is in that situation where you've got a raised serum AFP, you don't have to take millions of blocks of the testicular tumor to identify the non-seminoma. On the other hand, if you've got a pure seminoma, even if you've got 1% of non-seminoma, they will treat the patient as a non-seminoma. So in a seminoma, search very, very hard for a non-seminomatous component. Once you've diagnosed non-seminoma, the presence of whether you got seminoma in addition, it doesn't really matter.
Fantastic tips, sir. Fantastic. I think these are pearls of wisdom from Verma sir, and you should all take home these messages, because these are day-to-day problems which you will come across once you start becoming practicing pathologist. I'm sure there are several practicing pathologists. Are there any questions, Dr. Tala?
Yes, sir. There are a few questions. The first is from Dr. Vanessa. She asks, which cell will take high molecular weight cytokeratin in the SNI of prostate?
Basal cells? You mean to say HMWCK?
Yes, she's just asking which cell will take up the high molecular weight cytokeratin in the SNI of the prostate.
Yes, there's a basal markers. High molecular weight cytokeratin is a basal marker.
Okay, sir. And Dr. Surbi is asking, when do we use the term adenomatous and when do we use the term adenosis?
I don't use both of them, to be very frank. I do use them very, very rarely, because most of the cases I see are malignant, frankly. Verma, sir?
So I think this is where I think this is confusion caused by experts. So we had two sets of experts. It was David Bostwick at the Mayo Clinic and Jonathan Epstein at Johns Hopkins, who gave different names for the same entity. So adenomatous, atypical adenomatous hyperplasia and adenosis is the same entity. It's just two different names for the same thing. The current recommendation is not to use the term atypical adenomatous hyperplasia because it has no pre-malignant implications. So use the term to essentially call these. I don't, if I've got a case that looks obviously benign, I don't bother to use the word adenosis. On the other hand, if I've got a case from outside which has been diagnosed as prostate cancer and I am changing it to benign, I would then use the word adenosis to explain why the outside pathologist had considered this to be cancer. So there is no, the point I'm trying to make here is the important distinction is between benign and malignant. It is not important to distinguish between the different mimics. So whether it is atrophy or partial atrophy or post-atrophic hyperplasia, doesn't matter. The important thing is it's not cancer.
So regarding that case of a seminoma, Dr. Babita is asking, what is the significance of smudge nuclei in that case?
Nuclei, sorry?
What is the significance of smudgy nuclei in that case of seminoma?
No, see, many of these germ cells, they are so fragile and all, they get smudged. So especially if you have, say, a retroperitoneal mass and you do a biopsy, many times you just see crush artifacts. You will not find typical well-preserved cells inside. During the process, when you are pulling out these needle biopsies, there is a lot of friction and it can really cause smudging of these. The point is, they can get smudged and they can look very crushed in many of these biopsies because germ cells are very, very fragile germ cells.
Can I ask one question to the students?
Sure, sir, please.
If you've got a lymph node, which is extensive granulomas. Now, obviously, in India, the first thing you think about is tuberculosis, right? Okay. But no necrosis. So which are the two cancers that you should exclude? So one, as Santosh just said, is seminoma. You can get something that looks entirely granulomatous, and then you find these rare seminoma cells within it. Which is the other one?
Yes, anybody? Yes,
I think Munda has got very lymphoma, Hodgkin's. That is absolutely right. So Hodgkin's lymphoma can have, purely granulomas, and you really have to search for the Reed-Sternberg cells in there. So before you diagnose something as sarcoidosis in the West or tuberculosis in the East, one of the two things to think about is seminoma and Hodgkin's, especially in the exam
is also there. Dr. Gujal can vouch for it. Hodgkin's lymphoma showing granuloma, sir.
Yes, it's pretty common. I agree with you. Means these are lesions which are rich in histiocytes in the background. There are so many histiocytes, and you can find granulomas with that, and we all make mistakes there. Yeah, very well, valid point. Thank you.
Sir, one more question. What is the management of surface type of urothelial carcinoma that exhibit micropapillary morphology? Does it require radical cystectomy?
No. I don't think a surface like micropapillary, which is non-invasive, like sir said, we don't call it micropapillary carcinoma.
Am I audible?
Yes, you are audible. Am I audible? Hello?
Yes, sir. You're audible, sir.
Yeah. So surface type micropapilla, generally high-grade urothelial carcinoma, they are treated like high-grade urothelial cancers, which are non-invasive. So they would receive BCG, intravesical BCG therapy as others. So as long as they are non-invasive, we don't label them as micropapillary urothelial cancer. We call it surface micropapillary pattern in a high-grade urothelial cancer. And they would be treated like that. So only when they become lamina invasive, a thought. So I'm still saying it's a thought that many of, if it is widespread micropapillary pattern in a TURBT specimen, sometimes our clinician, I don't know whether Verma sir has the same experience, our clinician get alarmed a little bit if the micropapillary pattern is very predominant. They would consider radical cystectomy in such patients, even if they are T1 and not T2.
Especially in a deep T1. So there are some centers in the, like I think MD Anderson, but certainly some centers in the US where they would routinely recommend radical cystectomy for a T1 micropapillary. For us, our surgeons tend to be more circumspect. So it's usually in a case where you got a deep T1, where the tumor is almost abutting the muscle. You have not seen any detrusor muscle invasion. In those situations, they might recommend radical cystectomy. I think, Santosh, can I make one relevant point? I think that pathologists and urologists sometimes don't speak the same language, and it's important for us.
Many times they don't speak the same language.
Yes, and sometimes it can be quite problematic. And one of those is invasive bladder cancer. When the urologist is talking about invasive invasive bladder cancer, he's talking about T2 disease, and he's thinking about radical therapy. When the pathologist talks about invasive bladder cancer, he's talking about invasion as in any other organ, which can be either T1 or T2. So what I would recommend is don't use the word invasive on its own. So say detrusor invasive or muscularis propria invasion. The other point is that the urologists do not recognize the presence of or do not appreciate the presence of muscularis mucosae. So when they say muscle invasive, they're talking about detrusor muscle invasion. So again, don't use the word muscle invasive in your report. Say it's invading the muscularis mucosae or invading the muscularis propria.
Dr. Arun is asking, what do you suggest to the PG student who study in an institute where IHC workup is not available for such case? How to tackle such situation?
Oops. That's a difficult question, Dr. Atul. You said Dr. Atul? Arun? Dr. Arun, that's a very difficult question. But I think the pillar of pathology is histopathology and your basic HE stain, coupled with your knowledge of your basic medical science, of your basic MBBS, it comes into play. And like I said, before you look at a slide, you should, if you know the investigations, the radiology, the clinical picture, age, site, most of the diagnosis, you are already on your way to the diagnosis. It is only in difficult situation where you are really struggling with a benign versus malignant diagnosis and it has got serious implications. You would want to do IHCs and you cannot run away from the fact that those cases, those are the real scenarios where IHCs are necessary. Obviously, the subtyping of all cancers requires IHC. You cannot diagnose lymphomas without IHCs. You cannot sort of distinguish them from other poorly differentiated tumors. So my point is morphology is the cornerstone. But yes, in a center where you are doing oncopathology, I don't think you can progress much ahead without the use of ancillary techniques like IHC molecular in the current era. Verma sir, you want to add something to that question? It's a very pertinent question.
But on this, I totally agree. There are situations which you cannot do without immunohistochemistry. But on the other hand, I think we all overuse immunohistochemistry. I think there's a lot of like testicular cancers. 90% of 99% of testicular cancer reporting does not require immunohistochemistry. It's purely morphology based. So, but the number of cases, certainly in my institution and in the West, there's far too much immuno done. There's immuno done to distinguish between embryonal carcinoma and yolk sac tumor. Now, if you understand how testicular cancers are treated, embryonal carcinoma and yolk sac tumors are both non-seminomatous tumors and would be treated in an identical fashion. So in that situation, you don't have to waste time, money, and resources doing immunohistochemistry. So I'm not saying, while on the other hand, the type of prostate cancers that I worry about day in and day out, the early prostate cancers, which you see much less of, I can't do without immunohistochemistry. Right. So if you've got advanced prostate cancer, you often don't need immunohistochemistry. Your main reason you need immunohistochemistry is to make sure it's not bladder cancer. So distinguishing prostate cancer from urothelial carcinoma. While for me, I would not be able to report prostate biopsies where I've got these small gland proliferations and trying to distinguish benign and malignant without the use of immunohistochemistry. So it's all about where you need immunohistochemistry, but you use it, I think, as Santosh said earlier, to use it judiciously. I think the other, I think I should make the point here. I think it's valid. So when I come to India and teach, I feel very embarrassed, to be honest, because the Indian pathologists are much better morphologists than any of the Western pathologists are, and the reason for that is you all have to, one is you have to depend a lot of you grew up without immunohistochemistry. So you are dependent on morphology. And secondly, your morphology quality of the sections are often not as good as what you get in the West. So you have to be an even better morphologist to compensate for that. So I have great respect for the morphologic abilities of Indian pathologists. So learn from your teachers.
Thank you, sir.
One last question. It is in regard to the grossing of testes. Which is the better way to gross? Full thickness cross section or only from the periphery?
No, I didn't get the question. Full thickness cross section means through and through. You have to take.
I think she's asking in context with the grossing of the testes that you were showing.
No, I don't think it is a question pertinent to testes. Through and through sections related to prostate.
I don't know. So which context the question is saying that which is the better way to gross? Full thickness cross section or only from the periphery? I don't know which.
I don't know which organ. I can't make out which organ.
If it is a testis, then definitely full thickness, because what you want, the key thing in testis is not the microscopy, it's a macroscopy. So when you got a pure seminoma, the key point is to identify any cystic areas, hemorrhagic areas, areas that might represent non-seminoma and sample that. So unless you take full cross sections and thin slices, can I ask the students, if you've got a testicular cancer and you submit all of the testicular cancer in the histology, what percentage of the tumor do you think you've examined? The tumor have you examined when you all examine where you all submit the whole of the testicular tumor? So suppose you've got a 10 centimeter testicular tumor and you've taken 50 blocks or 70 blocks and you've all embedded it. What percentage of that 10 centimeter tumor have you actually looked at under the microscope? Because clearly you have not examined all of it. There's a significant amount that is still left in paraffin. So what do you think is the percentage? Have a guess.
Wild guess. Come on, Parul.
7 to 8%, 10% maximum.
8%, 7%. Anyone else?
10 to 20%.
10 to 20%. I've got somebody here who says 1%. The correct answer is 1 5 micron section of a 3 millimeter. So if you take thin slices, 3 millimeter, it would be about 0.15%. So when you all examine a specimen, so radical prostatectomy, you all embed the radical prostatectomy, you have examined 0.15% of the margins. So again, to the point I'm making here, in a testicular tumor, the critical bit is not taking a lot of blocks. If you double the number, if you take double the number of blocks, you have only examined an extra 0.07%, which is minuscule. The key thing is a macroscopy, that you take thin slices, let it fix properly, look for areas that look different, sample those areas. It doesn't matter how wonderful your histopathologist is, if you haven't sampled it, they can't diagnose it.
I think if there are no further questions, Dr. Tala.
No, sir. Thank you so much, Santosh sir. Thank you, Murali sir. Thank you so much. Thank you for having me here.
Thanks to Verma sir for taking time out. Verma sir, thank you. Seriously.
Oh, it's an absolute pleasure. Thank